So while waiting, so I just, even though there's a few people have joined already, so I just brief about the spice route. Everyone knows about this spice route. What's the spice route? It's a young members movement of doctors of family doctors movement, Wonka. Actually, we have the South Asian young doctors called spice route. From this, Sri Lanka is one of the country from this, and we are one of the active movement. And the GP Café, actually we started actually earlier started with the physical case-based discussion. Then it will go into the hybrid one, or maybe nowadays we do the online one. It's a proud moment. Actually, we have completed 4 years in recently, and now we are on the 5th year. So we had several very interesting case discussion, and actually it's one of the prominent among the region even. So actually we have that shown our interest to in the all this like clinical arena, as well with all how this group made things for the family medicine. And so thank you everyone for the joining, and I'll show next slide. This is actually I talk about that. So anyone can be joined if you have young doctor within 5 years of or within training the first postgraduate degree, or and also in any associate members. Actually, as anyone associate with who are doing the GP, they can be the associate member. So with that one, within 5 years, they can be joined. So we will go ahead and I'll invite Dr. Shamin to start the session. Thank you all.
Thank you, Dr. Gobik. Good evening to everyone. On behalf of Spice Route Young Doctors Movement, I welcome you all to today's session of GP's Cafe. Let's together make this session very interactive, and please be free enough to ask any questions or share your experiences at any point in this webinar. So without further delay, let me introduce the guest speaker for today, Dr. Aysha Ziauddin. So Dr. Aysha has done her MBBS in Nottingham, UK in 2007. And afterwards, she pursued her career in obstetric and gynecology. And she has done the MRCOG. After which she switched on to family medicine, and she's a qualified MRC GP UK. So she has special interest in many topics related to gynecology. And today she is going to share a very interesting case and a scenario. So let's get ready to witness what she has experienced. Over to you, Dr. Aysha.
Thank you very much, Shamim. I'm just going to share my screen. Can I just check you all can see the right thing?
Yes.
Yeah, you can see. Okay, hi. So thank you very much for having me, Spice Route. It's a pleasure to be here. So my talk today is the Unsung Lullaby, because I'm talking about the most common cause of women in our region having subfertility. So this is why it's called the Unsung Lullaby. So I'm going to discuss the case. I'm going to go through the case that I saw in my clinical practice. I will talk about the pathophysiology of the condition, the diagnosis, how we investigate, the treatment, and as we are all family doctors, the most important part, the long-term sequelae. Like Dr. Sharmin said, I'd love it to be interactive. If you have any questions, please stop me. Any comments, please just say. And then also there is a Q&A at the end if you want to ask at the end as well. So this is the history. It's a 32-year-old lady of Sri Lankan origin. She'd been trying to conceive for 3 years with regular intercourse. She described oligo and amenorrhea, and also described some acne on her face and her back. This is the first time she had sought help, and then she'd seen me in a primary care setting. She had no past medical history of note. She was a teacher. She had been married for 6 years. They'd stopped using contraception 2 years after marriage. She did not smoke, and her husband was an IT consultant. So her agenda, her ideas, concerns, expectations of you all who've done the MRC GP was subfertility. It was a huge upset to her that she'd been married for 6 years and didn't have a baby. And she was very upset because younger siblings, younger cousins, people who'd been married a shorter period to her had had a baby. And she had a lot of psychological pressure from her family, from her in-laws, from, she'd go out places and people would say to her, "You don't have a baby yet." And this was causing her a huge, huge upset. And she came quite distressed, actually, that she hadn't conceived. I couldn't really explore why she'd waited so many years to come. But I think they just thought it would happen, and it didn't happen. So that was the history. Family history of note, there was nothing of note. So on examination, she had a BMI of 32. Obviously, in Asian women, we say that if they have a BMI of this, it would be more obese than overweight. Hirsutism, she had a significant facial hair on her upper lip and her chin, which she was removing through threading, and also some on her breasts. She scored 8 to 9 on the Ferryman-Galloway score. I'll be talking about that score in a little bit more detail later on. She had acne on her face and her back. And importantly, she had no cushingoid or hypervirilization features. So she had no moon hump, she had no thin skin, she had no moon face, she had no striae. And in terms of hypervirilization, she had no deepening of the voice, no clitogomegaly, or no changes in behavior or libido. So that's an important negative there. So her bloods were done. Her FSH was 5 and her LH was 15. Please note the ratio of these two numbers rather than the absolutes. Her testosterone was high, as you can see. Her TSH was normal. Her scan was normal. There's nothing on scan. And her HbA1c was 6%. Yes, these were her bloods. So just to say, FSH as LH were normal in value and testosterone was high. Those were the two main things. But if you look at the LH, it was higher than the FSH. So does anyone want to give me a diagnosis? Or differential diagnosis?
Polycystic ovary disease.
Exactly, yeah, exactly. So it is PCOS indeed. So her management, so this patient was very motivated. She was a teacher, she was very educated. So she did a lot of reading and she came to the conclusion with me that for her, the low carb diet was the way forward. There's a lot of things online about this and she decided it was the way forward. We also discussed metformin, which she went on. And she went on that without many side effects, folic acid, obviously, and she lost 15 kilos. So she did really, really well. So we referred her to infertility clinic, but before she could see someone, she conceived naturally, which was lovely. She went on to have a baby girl, but however, the pregnancy was complicated by GDM on insulin, but the baby, it was a healthy baby and a healthy mom. So at the end, it was a lovely outcome. And it was nice to see how primary care management got her there, even before secondary care could see her. So polycystic ovarian syndrome. Polycystic ovarian syndrome is one of the commonest causes of infertility. It's a very high prevalence in our society, and some of the numbers are saying even up to 25%. Interestingly, in Asian women compared to Caucasian women, the severity of the symptoms are greater. We're not sure why that is, maybe due to the insulin resistance. But so even if you read the literature, obviously it's mainly based in the West. But for Asian women, it is more severe than it is for white women. And like I've harped on before, there's very important long-term sequelae when a woman is diagnosed with PCOS. It is just not, she can't have a baby. So the pathophysiology, the first thing is, as I'm sure you guys know, PCOS is a misnomer. On scan, it does look like cysts on the ovary, but they're not cysts. What you can see are little immature eggs. So in PCOS, what happens is several eggs start developing and then stop in the mid-follicular phase. And instead of one ovum developing and ovulating, all of them just stop. So that's why on scan, you will see the PCO appearance. And also it is really linked to insulin resistance. There's a lot of discussion, chicken or the egg, does PCOS cause the insulin resistance, or does the insulin resistance cause the PCOS? And that's, still debated quite a lot in the research, and people haven't come to a conclusion yet. So this slide, it's a busy slide, so bear with me. So here, so basically, PCOS is thought to be hormonal imbalance, insulin resistance, and hyperandrogenism. And all of these three are connected together. So they're all interlinked. So the first thing is the hypothalamic pituitary ovarian dysfunction. In PCOS, there's increased LH surges. These LH surges cause the theca cells of the ovary to increase their production of androgens. These androgens go on to not allow ovulation, thus the anovulatory infertility and menstrual problems. The androgens also go on to cause fat deposition. Fat deposition causes insulin resistance, Insulin resistance causes higher level of insulin to be produced in the body. This increased insulin, therefore, causes the liver to reduce the serum human binding globulin. So this SHBG is basically a hormone that binds to testosterone in the body, and the lower the SHBG, the higher the free testosterone in the body. And having increased insulin levels decreases the SHBG. Androgens also can directly impact, so having increased androgen levels also directly impacts the ovary to again cause more ovarian production of testosterone. There's also an element of aromatization where the ovary produces increased testosterone, the theca cells produce increased testosterone, and this testosterone is converted by the aromatization enzymes into estrogen. This estrogen also goes and affects the HPO axis. So it's a big cycle that causes the problem. But like I said, there's still a lot of discussion. Is it chicken or egg? Is it the hyperandrogenization causing the insulin resistance, or is it insulin resistance causing hyperandrogenization? So the clinical features of PCOS. I think we're quite aware of this, but oligoamenorrhea. So just to say, oligo is obviously a period every 3 to 4 months, while amenorrhea is no period in 6 months. Acne. So acne for women with PCOS can be quite distressing. It can be cystic acne. And also in our region, Asian skin has more melatonin, therefore has more risk of hyperpigmentation. So that's a big thing. The hyperpigmentation can cause a lot of upset. Acne, if it's cystic, can also cause scarring. Hirsutism, as we discussed again, is because of the hyperandrogenization. This too is a very disturbing feature for women. Traditionally, women were called bearded women because of their symptoms. And this was the stigma they had. Obviously in Sri Lanka, we do reduce facial hair by things like threading or laser. But still, even with the laser treatment, which is quite expensive, it can come back with PCOS. Another thing you have to note with women who have PCOS, and if they keep on plucking, is that they can get pseudofolliculitis barbae, which is quite a distressing disorder where they have lots of pustules in the area that they've continually plucked. And this is a very upsetting and painful complication of hirsutism. Obesity. So women with PCOS generally have frontal obesity and central obesity. As we are aware, this can obviously is linked higher to the CVS problems and heart disease. And like we're discussing today, like the Unsung Lullaby, PCOS is the #1 cause of anovulatory infertility in women. And most women, the highest cause of infertility is anovulation. So for a lot of women, subfertility is their main concern. So when it comes to the clinical features, this is what they use, the Ferriman-Galloway scoring. And it's a way of looking, can I just check, can you all see the screen okay?
Yeah, we can
Sure.
see.
Okay, lovely.
Yeah.
Ferriman-Galloway scoring, and it's just a way of scoring the hirsutism. For example, here, you can see the upper lip, how it's scored from 1 to 4, the chin, the breast, the back, the pelvic area. And in clinic, the women are given, and you do with the women, a table where you fill up and you tally these numbers up. And a score of 9 is considered to be hirsute. So this is just a nice way of objectively scoring hirsutism. Obviously, also culturally, so they say Asian women are generally naturally more hirsute, but I think this gives you an example of how bad things can get as well. So the Rotherham criteria. This is a criteria that was done in Holland in 2003. And it led to a 50% increase in the diagnosis of PCOS. And like in our example, that lady did not have PCO on ovaries, but had the other 2 features. So just to go through it again, you need to have 2 of the 3 criteria to be diagnosed PCOS. So you need to have oligo and ovulation, hyperandrogenism, either clinical or biochemical, and polycystic ovaries on scan. So this is quite important for patients, because think, for example, you have a woman who doesn't have PCOS on scan, as in our case study, but have the 2 other features. They can get quite shocked that they've been given the diagnosis of PCOS. And on the converse, you do get some women who do have PCO on scan, but have no symptoms and their blood tests are normal. And they're quite surprised they do not have PCOS. So it's important, for patients as well to know this. It's important here that they talk about, that you have to rule out congenital adrenal hyperplasia, androgen secreting tumors. Obviously, in this case, you'd have hypervirilization of women, Cushing syndrome, thyroid dysfunction, hyperlactolemia. So obviously, if a woman does have headaches and symptoms of mass occupying lesion in her head, or any prolactin type secretions from her breast, then you would do a prolactin. But it's important that we rule these things out before we give them the diagnosis of PCOS. So the investigations we should do are a hormone panel. So an FSH, an LH at day 1 to 5, and a day 21 progestogen. The day 21 progestogen indicates whether a woman is ovulating or not. Now, interestingly here, if a woman, we say day 21, if a woman has a 28-day cycle. If a woman, for example, has a 30-day cycle, you would do 30 minus 7, so you would do a 23-day progestogen. If she has a 32-day cycle, 32 minus 7 is 32 minus 7 is 25. You do a day 5 progestogen. So it's basically 7 days before the next period is due. That's the progestogen. That's the day 21 progestogen. You can also do a SHBG, which is the serum human binding globulin hormone. Only thing is in Sri Lanka that is quite expensive. When I've tried to get patients to get it done, it's been a lot more expensive than the other hormonal tests. A testosterone is very important. Once you have a testosterone and an SHBG, you can find out the free androgen index. And that's so the free androgen index is what tells you how much circulating testosterone is in the bloodstream, and that's causing the problems. A TSH is obviously important in any menstrual problem. And an HbA1c, as we've been going on about insulin resistance, so you do need that. LFTs are important because of metabolic syndrome and fatty liver, and ultrasound. And if the patients come to you for if she's come to you for subfertility, you can consider doing tests of tubal patency. So it's really important here that we talk about male factors, because a woman, 35% of patients, of couples who come to you with subfertility, it is a male problem. So even if you are 100% sure that this is PCOS, that it's completely, barn door, it's everything says PCOS, it's so important you do a semen analysis. And I've seen it here time and time again, where women are put through such a rigmarole of lapendides, HSGs, clomiphene, letrozole. These are really invasive and medications that have side effects. And a semen analysis has not been done. So I know one patient, she was diagnosed with PCOS. She went through 3 years of treatments, as in not IVF, but had like lapendides, ovarian drilling, clomiphene, and no one had done a semen analysis. They finally did a semen analysis, and he had azoospermia secondary to mumps. And it took 3 years of this woman to go through all of this for a semen analysis to be done. So please, please, please make sure before you refer to anyone, you please do a semen analysis. And just to remind you, for a semen analysis for a man, they aren't to ejaculate for 3 days. They shouldn't have herbal medicine for 3 weeks prior. The sample should be in the lab in 30 minutes, and they shouldn't use lubrications when they're trying to get their sample. So treatment. In PCOS, lifestyle measures are key. So as primary care physicians, we can do so much to help these women. The first thing would be weight loss. And weight loss really does help with insulin resistance. Now, there's several different ways a woman with PCOS can try to lose weight. It is, they say, more difficult with insulin resistance to lose weight, but there are things that can help. So the ways to change your diet with PCOS include low carb. So David Unwin in the UK is very much a proponent of this, and also it's Jason Fung in America. Again, he's really, they are the main Western proponents of low carb, and obviously in Sri Lanka as well, it's Dr. Janaka Wanaku, and Dr. Wanaku is the main proponent in Sri Lanka of the low carb method. Keto, again, is similar. Those 3 doctors, again, talk about keto in a great deal. The calorie deficient diet, so just eating less food, eating less calories, can help women lose weight. And there's also, if you should talk to our lifestyle medicine colleagues, plant-based diets have seen a hugely popular and can help as well. It's really important that these women exercise. There is a lot of evidence to say that strength training is particularly helpful in women with PCOS. And I don't mean going to the gym and like lifting heavy weights. It's simple things like squats can really help. Push-ups can really help, just body weight exercises. Another resource that I often ask PCOS women to look at is the Glucose Goddess on Instagram. So she's a biochemist who's done a lot of work looking at what causes glucose spikes and insulin spikes in our day. And she propagates things like having a high protein breakfast rather than a sweet, high carb breakfast. If you're eating, if you're eating rice and curry for lunch, you eat the vegetables before you eat the rice. Having a walk immediately after eating, which is obviously an Ayurvedic principle, where they say you should walk 20 minutes after eating, but she says the same. Obviously, it makes sense because you have a glucose spike after eating. If you go for a walk immediately, your body utilizes the glucose. And she also talks about things like apple cider vinegar, but I I personally haven't looked into that too much, but she's definitely a good resource to ask your patients to look at, and that's the Glucose Goddess on Instagram. The other thing about lifestyle measures, as we as doctors can do, is things like motivational interviewing and seeing, why are these women losing weight? And most of the time, most women know exactly what to do to lose weight. It's just that something is stopping them doing it. And one of the most satisfying things to do as a family physician is looking into that and looking into seeing why they're struggling and what is causing the lack of consistency or the lack of planning and making a difference. A lot of women sadly emotionally eat, and giving them strategies to combat emotional eating often causes really good results. So being a GP and a family medicine physician, you can really, help women ask themselves these difficult questions and get to the bottom of it. We know that stress increases cortisol levels, and cortisol levels are negatively impact insulin resistance. So it's important to discuss with the woman to make sure she's getting enough sleep, and also things like stress relief, so meditation, for example. Acupuncture, there are some studies that say that things like acupuncture help with PCOS, and then in the medical model, we'll say maybe it just reduces stress levels, but I've seen it work quite well in some women, incidentally. Now, gut biome, I'm sorry for my typo there. So any of you guys who came to the MCGP conference in the beginning of July would have seen that nearly all the specialities, from liver consultants to the cardiology consultants to the immunologists, discussed gut biome. And it's really interesting because I was reading the research for PCOS as well. PCOS is also linked to gut biome. So it's interesting looking at things a woman can do to increase her gut health. And, obviously you could just prescribe some probiotics, but it's always better to look at things that she can do for herself organically and without the need of medication. So in Sri Lanka, we obviously have the traditional diaba, or tani sora they say in Tamil, where you have the rice from the day before and you soak it in water and cook it later on. That is a fantastic source of probiotics. Buffalo curd is a fantastic source of probiotics, and so is lime pickle. So that combination, I was advised by a lifestyle medicine, lifestyle practitioner, is fantastic for your gut. The next thing is metformin. So metformin has not been licensed to help with PCOS, but obviously we use it. And the way it works is twofold. The first fold is it works with insulin resistance. It brings down the increase of gluconeogenesis by the liver, therefore reducing the hyperinsulinemia. However, it also reduces the theca cell production of androgen. So theca cells of the ovary, it works on them to reduce their androgen level as well. So it's widely used with good results. Now there's more research to say supplements help as well. So inositol is used, and again, a lot of women have very good results with it. We're not exactly sure how it works, but it seems to work very well. And also like coenzyme CoQ10 as well is thought to help with PCOS. So as you can see here, like as a family physician, we have, we can do so much to help these women before they go into secondary care and have those sort of treatments for other treatments that the gynecologist can give them. So these are specifically fertility treatments. And if you are a family physician who is comfortable giving clomiphene or letrozole, please, please, please make sure you do follicular scanning, because women with PCOS are at risk of ovarian hyperstimulation syndrome. And I have looked after several women with OHSS, and some of them have been on ICU. And I had one patient, I worked in a unit where the year before a patient had just been given 50 milligrams of clomiphene, which is the starting tiny dose, and she died of OHSS. So, it's something that we shouldn't take lightly. So Clomiphene is used a lot. Clomiphene is an estrogen receptor modulator. So it works by generally either antagonistically or agonistically, but generally in PCOS, it works by working antagonistically. So therefore, we're going into the estrogen receptors and increasing the GnRH production, therefore hopefully kickstarting ovulation. We spoke about metformin. Letrozole is an aromatization blocker. So we spoke about earlier how estrogen, testosterone is converted to estrogen if it's in excess. It stops that pathway. And then again, it helped with the negative feedback. Ovarian drilling is used by some cases in some women who are clomiphene resistant. It's not done as much as it used to be done. There's some evidence to say that ovarian drilling reduces the follicular count, it reduces the AMH of women. And obviously, then there's IVF. Interestingly, in the literature, IVF was considered third line. So, often it's considered, if you've got someone with unexplained infertility, it's first line, but in PCOS, it's considered third line. But in my practice, I've seen quite about at least half of PCOS women who are resistant to clomiphene and letrozole going on to having IVF. Obviously, IVF in general does not have the fantastic success rate. But another thing, obviously, about the IVF is the emotional, physical, and financial burden of IVF. So if we can optimize women by getting their weight down, getting them insulin sensitive, their chances are a lot higher. So the long-term sequelae, if no one listened to anything, in it, but if you could listen to this one slide, as general practitioners, this is our thing, because if a patient sees a gynecologist for PCOS, they'll have their baby and they won't go back to the gynecologist because they've had their baby. So this is where, we come in. And a patient with PCOS generally has metabolic syndrome. And with their metabolic syndrome, they have their insulin resistance, they have their diabetes, they have their fatty liver, they have their hypertension. So these are all things that we as general practitioners, family medicine doctors, need to have a look at. They need, we need to explain to these patients that if they have PCOS, they most likely at some stage in their life, if they don't already have it, have these conditions as well. There's also a thing to say that sleep apnea is a lot more prevalent in ladies with PCOS. They're not sure if this is linked just to the obesity. So obviously having obesity will increase your neck circumference and make you more prone to it, but they think it's separate to that as well. And sleep apnea, we know, causes insulin resistance as well. It increases your cortisol level, therefore increasing your chances of going on to have problems later on in life. So it's an important question to ask the partner. Does your wife or your partner snore when she sleeps? And does she ever wake up gasping for breath? And it's also worth asking the lady, do you have any problems sleeping in the day? Falling asleep, driving, and there's a score you can use, the Epworth Sleepiness Score, which can tell you whether they do score for sleep apnea. We do know women with PCOS have increased risk of CVS disease. Again, that is generally due to the metabolic syndrome, but rates of heart disease, ischemic heart disease, etc., are higher in women with PCOS. So for example, in the UK, we use the QRIS score to determine whether a patient goes on statins or not. The QRIS scores like that are not validated for women with PCOS. So the argument is you shouldn't just rely on a low QRIS score when discussing cardiac risk factors here, and you look at the woman holistically. Uterine cancer. So we know that high levels of estrogen cause hyperplasia of the endometrium, and hyperplasia of the endometrium causes endometrial cancer. So women with PCOS, if they are amenorrheic and not having withdrawal bleeds, are definitely at higher risk of endometrial cancer than a woman who is having regular withdrawal bleeds. And I think it's really important that we stress this to our patients, because sometimes they feel that they're not having a period, it's all well and good, but it's really, really important that we explain to them that no, if you are not on a pill and you're not getting a bleed, you need to come see your doctor to get one. and the psychological aspects of PCOS. Research shows that depression, anxiety, and stress levels are far higher in women with PCOS than in the general population. But you can see why. If a woman is struggling to have a baby, if she's struggling to keep her weight down, if she's struggling with acne, if she's struggling with eroticism, these are stressful things. And now in today's world with Instagram and, women are bombarded with what they're supposed to look like. It's very, very hard not to fit in to what society tells you to be. And I think for us as Sri Lankans, the infertility, subfertility is a huge problem, and it causes such difficulty for women. Often in our culture, women are seen as just a vessel to have a baby often. And, as soon as someone gets married, the next question is, when are you having a baby? And that is very, very hard for women with PCOS if they're struggling with that. So, as doctors, as family physician medicine, we really have to help with that aspect as well. So practically, as family physicians and as GPs, what do? We have to do yearly HbA1cs or oral glucose tolerance tests. In the research I was reading, there was some discussion that an OGTT is better than an HbA1c in PCOS, but I feel that a woman's compliance with OGTT will be a lot lower than an HbA1c. So if we can push for HbA1cs every year, that would be great. Yearly LFTs, if they're having abnormal, so it's no longer called non-alcoholic fatty liver disease, it's now called stereohepatic fatty liver disease. If you are concerned about this, do the NFLD fibrosis score, and say, obviously, if they can afford it, if they have abnormalities, just send them for a scan. But if money is an issue, then do the scoring system and see whether they should have a scan. Blood pressure checks are so important to these women, yearly blood pressure checks. And lifestyle changes, as we discussed in depth in the last slide. You are in such an amazing position to change these women's lives. And you can do what the hospital doctors just often don't have time and don't do. Like we said before, it's really, really, really important that they have a withdrawal bleed every 3 months. That can be norethindrone, 5 milligrams TDS for 7 days, and then stop it for a bleed. It's better if we can get Provera, but I've prescribed it, but I've struggled to get it in Sri Lanka recently. Failing that, the combined contraceptive pill. However, with the combined pill, if you've got a lady who's overweight and over 35, you can't really use it. And the next option would be the Mirena. But again, in the private practice, the Mirena is now very expensive. I was told by a drug rep, it's 50,000 rupees now. So these are things that we have to think about in Sri Lanka. But if you can remind a woman to put it in her phone to get norethindrone every 3 months to bring a withdrawal bleed, that would be so important. And psychological support. We need to reassure them that PCOS, though it has its problems, it is can be treated, that they empower them to do the things that they can do, and I feel that can really, really help. So in summary, PCOS is a leading cause of infertility in women. It has a long-term sequelae, and as for us in primary care, it is so important that we look after these women holistically and in the long term. So does anyone have any questions?
Do we have any questions from the participants? So that was very interesting, Dr. Aysha. The slides were so perfectly, and easy to understand. And in fact, I have a question, because PCO is actually pretty common and you do have people struggling with it. But it's very difficult to, give the support just to the lady. Sometimes, I feel the whole family needs the support, because, they don't take obesity as the main cause. They would, they always are more inclined to, feeding the lady, okay, maybe she's too malnourished, or, So how do you go about that? Like, How do you give that support to the?
So I think education is really important. So maybe you could explain to the family, could you ask the woman, can you bring your parents or your whoever they're living with in when you next see them? Because actually, you're right, it's a holistic treatment here. And if you would say if live in an extended family, you don't have much say in where perhaps the meals that are being cooked. But this is where things like menu planning make a big difference. So if you could sit with whoever is, if you can empower the lady with Peace to West to sit with whoever is doing the menu planning for the week and describe to them what they need to do, it makes a big difference. But there's simple things like, just having your plate, having more like more salad or more more malums on your plate than rice, and little things like that can make a difference. You don't have to. The problem with the internet is it's very Western based, and it says you need to buy this, you need to buy that. And protein is really expensive in Sri Lanka. You can't tell a woman to buy 250 grams of protein and eat, because how are you going to afford that? So things like, explaining to them, you can eat malums and you can eat haripus and dals and, green gram. Even things like soy are thought to be better, good for you and cheaper as well. So things like that. But it's education. If she can bring her family members to see the family medicine doctor, it would make such a difference, I feel.
That's correct. So still, I think there are already people, like we have a nice crowd, and I think people are saying thank you. Thank you, Dr. Aysha. So we really enjoyed this session with you. And on behalf of Spice Route, we do have a certificate for you.
Oh, thank you.
Okay, so I think you can collect things from the college, hopefully, or if you want, we can arrange it to be delivered, whatever is convenient for you.
Yeah, printed one we will send it later. But anyway, at the moment we will in the virtual ones, in the online one to you. Please accept this.
Thank you very much. That's very kind.
I thank all the participants for joining us today. Thank you for making this session, and thank you for listening and being here today, and for your time.
Thank you very much for inviting
Thank you,
me.
everyone.
Thank you, everyone.